Okay, I would like on this Tuesday, January the 19th, 2021, introduce Richard Mollot. Richard is the Executive Director of the Long-Term Care Community Coalition, which is a nonprofit organization dedicated to quality of care and quality of life for people in nursing homes and assisted living. That's their mission statement. We've asked Richard to talk to us about that most intriguing and just breathtaking topic of data and how we can use data to improve the quality of life. So what I'd like to ask at this point is to have everyone mute themselves and to turn off your cameras. And if you have anything that you'd like to say, please put them in the chat. And Richard has left some time at the end for questions. So Richard, I'm going to turn it over to you to share your screen and anything else that you want to do.
Great. Well, Carol, thanks so much. Thanks so much for inviting me. And this comes from a program that we did 2 years ago, I believe, at the Consumer Voice Conference. We did a post-conference intensive on using data to strengthen your nursing home advocacy. And I should preface this by saying that I do not have a data background. And in fact, I got a D in statistics in college. And all this stuff was really fuzzy to me. It doesn't take a genius by any stretch of the imagination, or does it take someone who has a lot of knowledge or background. But I have found over the years that having data, having the information on what's going on in nursing homes, in the areas in which we're advocating, can be extremely helpful. So, and Carol, please let me know if I break up or something. And if I do, because I dropped off before, I'll of course get right back on. But again, as just Carol said, we're a nonprofit organization. We are actually the home to 2 local long-term care ombudsman programs in New York State, of which I am very, very proud to be hosting them. And it's just been a great symbiotic relationship for us to have those programs. Our work is, we focus on nursing homes and assisted living. We do at LTCCC predominantly state and national policy analysis and systems advocacy, and that's where we use these data. But we're also more and more over the past 8 to 10 years been doing a lot of education and outreach to consumers and families and ombudsmen and other stakeholders. I've listed here a couple of the resources that we have, nursinghomes411.org, which I will be referring to again. And of course, you can sign up for alerts and news, including when we have data updates of interest, by going to nursinghomes411.org/join. Also, I wanted to plug in, we do monthly webinars on residents' rights or other issues. Last week, we had an expert speak on vaccinations, and we have been offering them in our home state, New York, to the ombudsman programs that if they choose to, they can use that as a 1-hour in-service training for their staff or volunteers. And over the past few months, we've been opening that up. So essentially what we do is we have at the end of the program, there is a short survey, like a 4-question survey, just to verify that the person attended, and then we will share that information, those names, with their long-term care ombudsman program. So if you want to do this for your program on the local or the state level, you're more than welcome to just email sarah@ltccc.org to sign up, and therefore we'll include the program as the program's name as an option for people to do that. And it's free and hopefully of use and interest to people. So I want to talk about just a little bit about why these data are useful. As I said, we've been using these data in our systemic advocacy for many years. Essentially, it enables us to substantiate with data, with figures, with numbers, what is really going on. Lori and Carol mentioned the excellent report that the Consumer Voice came out with this morning. And I think there are different components, as I'm sure you all know, to advocacy. And part of that is presenting the consumer voice, the resident's voice, or the family member's voice. And that report, I have to say, is just remarkable in doing so. And also presenting a basis. And so a lot of what we do, as I mentioned, we do systemic advocacy, is looking at the rules, looking at the standards of care, and then using the data to evaluate the extent to which those standards are actually being implemented in residents' lives. It could also be used on an individual facility basis or on an individual resident basis. We've done this in our work with family and resident councils, where they can use that information to evaluate how their nursing home is measuring up to, for instance, state and national averages for staffing, for expected staffing from CMS, and which studies have shown 4.1 hours, as we in the Consumer Voice, of course, have been advocating for years, 4.1 hours of care staff time per resident per day. So there's really many different layers in which this information is useful. And I would also say, we're going to dig into this a bit in this program, but there's a lot of flexibility here. And as I said at the start, I don't have a background in data analysis, and it's very flattering. People have come to me, frankly, over the past several years and said, and asked me questions about the data. So it's nice to have that level of expertise, but that expertise is really not necessary, as I hope, I'll be able to show during this program. So I'm going to talk about a few different resources. The first one is Care Compare. Now, Care Compare is the new federal website. It used to be called Nursing Home Compare, and I imagine that you probably are all familiar with Nursing Home Compare. They just changed this, I guess it's been about 2 months ago, to Care Compare. They are, I think, making some further changes to it. I hope so, because we in Consumer Voice and for Medicare Advocacy have been advocating for some changes where we think Care Compare, that transition has not been helpful to the public in terms of finding information. But I want to just quickly go through Care Compare, and then I'm going to talk about a few resources that we work with to dig a little bit deeper. One is ProPublica's Nursing Home Inspect. The second is our website, nursingHome411.org, and then the underlying federal databases, data.medicare.gov and data.cms.gov. And before I move on, I have to say I was working on this program over the weekend and fine-tuning it and stuff, and I went back to data.medicare.gov and data.cms.gov, and it seems that they're consolidating them. So some of these things might change. We will always have the most updated information on our website. All of our resources, the data that we post, are based on the federal data, and we always include a link to the underlying database so that people can verify if there are any questions about the data that we provided, and making sure that's just not something I made up, but you can actually go back to the federal database. So we'll always provide updates to that, again, on our website, but there is just, unfortunately, some fluidity here as they are consolidating those different websites on the federal level. Lastly, the reason why they're doing that is because there have been a number of different compare sites, as they call them, for home health care, for doctors, for, I believe, hospitals, hospice, et cetera, and they're putting them all into one single site called Care Compare, which I'll show you. So just a very brief introduction, as I said, to Care Compare, which still has the 5-star rating system. It's medicare.gov/care-compare/. So it provides information on every licensed nursing home in the country. It does not provide information on so-called private facilities that are only private pay. We considered, I think, I can't speak for others, but we certainly consider to be the most reliable and useful resource for information about nursing home quality, whether you're talking to someone who's just coming in looking for a placement for a resident, or someone who is doing, maybe as an ombudsman, is looking into the facilities in his or her area or specific facilities. You can really find some useful information there. Again, none of the data are perfect. I'll talk about that a little bit more, but it is by far the best resource out there. What I wanted to mention, though, is I keep on saying, it's not perfect. One reason why it's not perfect is because really what we all look at, I mean, 5-star ratings just for anything, movies or restaurants, or in this case, nursing homes, are really valuable for providing easy to understand and accessible information for someone who's just coming in to where should I go to eat, or where should I go for nursing home care, and that seems really helpful. What I wanted to mention, and I included the link here, and I sent Carol the slides so you can, she'll have copies of that which you can share, for this report, came out about, I think 10 years ago. It's called Where Should Mama Go? And that study found that rating systems for nursing homes are much better at identifying poorly performing facilities than they are at identifying good facilities. And what that means in essence is that if you have a 1 or 2-star facility, you can be pretty sure that the care there is substandard. However, if you are looking at a 4 or 5-star facility, that does not necessarily mean that you're going to have great care. I mean, if I go to a 5-star restaurant, I assume it's going to be, just amazing. Whereas if you go to a 5-star nursing home, that's unfortunately not the case. And there are a variety of reasons for that. Essentially, well, this is the opening page to Care Compare, which I just wanted to show you. And you can see here how you can do a search by different provider types, et cetera. But I wanted to go to the actual listing. And this is just a listing I picked out. It's a Majestic Care in Columbus, Ohio facility. And so you can see here underneath the star ratings, they have underneath the stars, which it's got a 1-star facility, it has ratings, quality, details, and location. Underneath that, you have the overall rating of 1 star, and then the 3 different star ratings below it for health inspections, staffing, and quality of resident care. And the reason why the Nursing Home Compare is one of the reasons why it's imperfect, and the reason why these ratings are much better at identifying poorly performing facilities than they are at identifying excellent facilities, is because all of these 3 parameters have different levels of imperfection. So health inspections, for instance, this facility got 1 star, but as I think you probably have all seen, the state surveyors don't do a particularly good job in identifying problems. And even when they do identify that there's a problem, they tend to not do a very good job in identifying when a resident has been harmed. And therefore, a lot of substandard care is essentially swept under the rug by state and federal inspectors, surveyors. So that's problem number 1. And we've done studies on this, looking at national data. We're doing another study. We're in the process of doing a study this year, also looking at data for each state. It's something that the Government Accountability Office has also verified. The second parameter is staffing. And I would say, staffing, I think, is widely agreed to be the most important predictor of a facility's safety and quality of care. Now, the staffing data are not perfect, but I would say that they are the best data of these 3 different subjects, different areas. And we'll talk more about that later. And then lastly, in every way that I can think of, is what they call quality of resident care. They call the quality of resident care here. I've always objected to this because it's not really quality of care. This is the results or the outcomes of the reporting of the MDS, the minimum data set. So it covers the MDS covers a range of different issues, from pressure ulcer rates to antipsychotic drugging, to whether a resident became more depressed, whether they became incontinent. There are dozens and dozens of them. And they use a small number, I think it's about 8 or 12, I forget exactly, of all those MDS, of all the MDS questions, they use a small number of them for this quality of resident care rating. And this is, to me, from the very start, when I first started 18 years ago and had no knowledge of nursing homes, it seemed to me immediately to be kind of a ridiculous number. And that, unfortunately, has been something that has just been confirmed in my study and research and readings over the last 18 years. And the reason why it's kind of a useless number is because nursing homes assign themselves the essentially these MDS ratings. And so it's really, except for a few, and I don't want to spend too much time getting into it, except for a few, they're all based upon what the facility has self-reported, and they're not verified by either the state or the federal government. And as you can see here, and I come across this all the time, you have essentially a one-star facility. It has that red badge you can see right by its name, meaning that it has a history of abuse, and it has low staffing, but it has 4 stars for quality of resident care. And facilities will sometimes advertise that they have 4 stars for quality, 5 stars for quality, but in fact, that's not quality. It's really just, again, an MDS measurement tool. And even if it was, even with that being said, it is entirely self-reported and unaudited. The CMS has added a couple of claims-based data points there. For instance, rehospitalizations is not something that's self-reported by the facilities. It's something that's available through insurance claims data. So they've added a couple of points there to make this a little bit more accurate, but for the most part, most of those MDS measures that are used are, again, self-reported by the facilities, unaudited, and useless. And I pay zero attention to the quality of resident care star rating, except at times like this when I'm talking about how bad it is. So I'm going to quickly go through the Care Compare just for this facility, Majestic Care of Columbus, just to show you now what's on the new website, the Care Compare website. As you can see, it's a little bit cleaner. Those of you who have visited Nursing Home Compare in the past, I think it looks much better. I think, unfortunately, some of the information is not as clear or not as, it's a little bit harder to find than it has been in the past. But you can see here is under health inspections, it gives you the data of the most recent inspection. There's a line here you can click on, view full report, and it gives you, as they've done in the past, the total number of health citations and the average. It's maybe hard to see here, the average for the country and the average for the state. As you can see, this is much, much higher. Staffing here, it breaks down the information on the, so the average number of residents per day, the census gives you the size of the facility, the total number of licensed nurse staff hours. They break that down into the RN and the LPN hours. And this goes further down. I just took a snapshot of the top of the page, but you can see, you can find information about the total nurse staffing as well as the licensed nurse staffing. I would just want to add before we move on that I think we all realize that the certified nurse aides provide the vast majority of bedside care for residents. I think it's about 90%. However, I just want to plug in that numerous studies in recent years have found that the RN staffing levels have a critical role in the quality of care in the nursing home. And so that is something really important to look at, both the RN and I would say the overall, or the RN and the certified nurse aide, to see the extent to which there was an RN presence, as well as an overall staffing presence. The other thing that I've found, which I think I've seen corroborated in studies as well, but I've noticed this observationally, is that a number of facilities that I have visited on Nursing Home Compare, now Care Compare, that they will have large numbers of LPN staffing. Poor facilities will have higher numbers of LPN staffing and lower numbers of RN staffing. So that's something to look out for. And the reason for that is because LPNs obviously are much less expensive for the nursing home than our RNs. And we see, and we've seen this, for many years, of course, as I'm sure have many of you, that nurses, are asked to operate outside of their scope of practice. I mean, it's a serious problem, and that's what I fear is going on when you see a lot of LPNs, but not a lot of RNs. Again, study after study now has shown that really the higher the RN level, the better the care. And that's because RNs are the only ones in the building who can do a resident assessment, who can really provide that professional level of oversight from ensuring, appropriate infection control and prevention to some extent, but also ensuring that the appropriate protocols for care are being provided. And then lastly, here's the quality of resident care. And they break it down now into two different, again, under the quality of resident care, they break that down into two different stars. One is for the short-term stay and the other is for long-term stay. And I just wanted to show you, these are some of the categories that they have under long-term stay. As I said, there are dozens of them. We publish some of this information on a periodic basis, but you can always find out here, if you're looking at a specific facility, how they did on the long-term measures. And you have here, hospitalizations per 1,000 long stay resident days. It tells you whether lower numbers are higher or better. You can see, maybe a little bit hard to see here, but right under there is a little arrow on the second row. And it also gives you the national average as well as the state. So some of these things may be useful to you, especially if you're looking at a specific facility, or your ombudsman, your staff, or the local ombudsman are looking at a specific facility. Because, for instance, looking at the antipsychotic drugging rates, which is the third one down here, percentage of long stay residents who got an antipsychotic medication. Lower percentages are better. This facility had 13.4%. The national average is 14.2. The Ohio average is 13.9. So it's slightly below the national average. Again, these data are not perfect, it's self-reported, but I think some of these data are a little bit better than others. Hopefully, whoever coded the antipsychotic drugging understood what that was, and so that could be somewhat useful. It's important to understand that for all the data on Care Compare, it's risk adjusted. So the staffing information is risk adjusted, and these data are risk adjusted as well. So they're not the raw data, they're data based in some way or another, they're calculated based upon the needs of the residents. Pressure ulcer rates here is down 1, 2, 3, 4, the fifth row. So if you have a resident, for instance, who is at risk for pressure ulcers, you might want to look and see, or you might want to advise someone to look and see, well, look at the quality, so-called quality indicators, and see what their performance is on pressure ulcers. Here, this facility is actually a bit above average for both the national level and the Ohio level. So there's some ways in which these can be useful, but again, always taking them, I would say, with a grain of salt. I lastly wanted to just mention about the statements of deficiencies. So Care Compare does provide, under the inspections, you can see the most recent statement of deficiencies. You can see previous statements of deficiencies as well. I think for probably, the last 3 years or so. One thing that is important to keep in mind, and I'm sure this is something that we'll all be advocating for, with the new administration coming in tomorrow, is that a very important component of the statement of deficiencies is the facility's plan of correction. So as I think you probably all know, the deficiencies really, the statement of deficiencies spell out what the surveyor found and how they substantiated the violation, what they saw, what they were able to find. Facilities are required for virtually every violation to have a plan of correction saying what they're going to do. And this is in itself a big issue, in terms of our work around oversight and accountability. There's been a number of OIG reports now, Office of Inspector General reports, finding on individual states that they don't follow through and make sure that facilities are carrying out their plans of correction. But that is really valuable information, because if you have the plan of correction, you are able to see your ombudsman, your family members, your residents are able to see, what did the facility say it was going to do? What did it agree to do to cure the problem that was identified? And unfortunately, that is not required on Care Compare, but CMS does require it on the state websites. So I personally tend to prefer the federal website to the state websites. They're kind of all over the place. in my experience in terms of what they provide and the robustness of them, but their statements of deficiencies are required to have a plan of correction, whereas for some reason CMS on its own website doesn't itself publish the plans of correction. And as I said at the start, it's something certainly that we hope we can advocate to include there, because it really is important information. And of course, as you probably all know, facilities have to provide the statement of deficiencies and the plans of correction to people in the facility. So usually that's posted, in my experience, at the front desk or on a bulletin board. They're not supposed to make it hard for people to access the statement of deficiencies as well as the plans of correction, but those can be really useful in terms of our advocacy. So I'm going to talk about a few different resources that we use pretty frequently, and I think could be useful to you in terms of your advocacy and just knowledge of what's going on. This is the ProPublica.org. It's called Nursing Home Inspect. They've had this for a few years now. They did some really great reporting on nursing homes as well as on adult care facilities in the country. They still do. It's ProPublica is kind of like a muckraking, public accountability news/research organization. Excuse me. They do a lot of really good stuff. But this is their Nursing Home Inspect page, and it includes, it's always updated, includes very robust information in a way that is very kind of, I would say, specific. So for certain things, it could be useful or interesting for you to come here. I would say especially, if you're looking at some of the more systemic issues, if you're providing if you're speaking to your state legislature, can help you to get information about specific areas and or specific issues that could help support your advocacy. But right here on the front, on the landing page, you can see they show inconsistent deficiencies across the country, and they map out on the left-hand side serious deficiencies, fines, and infection-related deficiencies. And maybe hard to see here, but you can see the last map, which is kind of like a brown russet color. It goes from dark to light, dark meaning the higher number of deficiencies, and light meaning the fewer number of deficiencies. Now, again, this has to be taken with a grain of salt, not because the numbers here are invalid, but because, as I mentioned before, the states don't do a very good job in identifying problems, so that there's always that issue. But it does provide some really interesting information, excuse me. And what I'm going to do now is I'm going to go and I'm going to visit the site. So if you'll bear with me, I'm going to open up Safari, and here's Nursing Home Inspect. So I hope that you can see that pretty easily. And here's the page that I was just showing you, and you can see you can actually click on any state. So this is nice to say that you are in Texas. You can click on Texas. This is the fines, and you can get information about what is going on in Texas. But what I want to do is I want to show you, oh, here we go. So Texas tells you number of homes, 1,212, homes with serious deficiencies, homes with infection-related deficiencies, homes with at least one case of COVID-19, how many penalties were levied, how many payment suspensions were levied. So just so you know, and like as Lori was talking about at the very beginning in terms of that lawsuit, the use of civil money penalties, monetary fines, is, I think, one of the most valuable types of penalties that are available to try to get nursing homes to comply. And that's really the basis of the lawsuit that she was talking about. But payment suspensions is also a good remedy. There's a number of good remedies. Of course, the ultimate remedy is being removed from Medicare and Medicaid, which generally forces an operator to sell the facility or close. So this is some information on Texas here, but what I wanted to do, I'm just going to head back. So this gives you, again, if you're on the state level, looking at, shows you on the right-hand side, deficiencies by severity in Texas. So as you probably all know, deficiencies are rated in scope and severity from A through L. Anything from G above is considered harm. So you can see, and this is what we see state after state, is that most deficiencies, are rated as D, E, and F, meaning they have the potential to cause harm, but they didn't cause harm. And that's the fallback position for states, unfortunately. And the issue here for us, again, I don't want to digress too much, is that for the most part, with very, very few exceptions, unless G or higher is cited by the survey team, there is virtually no chance of the facility facing any penalty. So that means these are all healthcare deficiencies. You know, we're not talking about something on the outside grounds, or it's healthcare deficiencies. But for the most part, these 13, 16, over 20,000 deficiencies here that are rated below G, the vast, vast majority, that means that the nursing home is essentially being told, you were found to have a deficient practice, maybe you were found to have caused or allowed for abuse or neglect or even resident's death, but we're not going to punish you. And therefore, we're essentially saying to the facilities that this level of poor care is okay, because you're going to continue to get paid, but you're not going to suffer any penalty. And this is kind of in a nutshell, a lot of the work that we've been doing in recent years is really focused on that. So this provides some really useful information. Again, you could sort it, you could download it. But what I wanted to show you also on ProPublica is that you can do a search. So you can search within a certain state. You can see here the drop-down menu. You can search by severity, from L, most serious, to A, least serious, of course. And then, or you could search by keyword, city, or nursing home name. So I'm going to search for pressure ulcer, and I'm going to pick out Iowa. And I'll do all severities. I'll just see what comes up here. There we go. So here you can see, it gives you the list. You search for pressure ulcer, 269 results in Iowa, total of 874 deficiencies. But here you can see actually what the date of the citation was, and you could sort by date, you can sort by nursing home name, the city, the state, of course, and the number of deficiencies that were cited, and then the severity level. Some of these were pretty high, which is good. And then if you click on it, I'm just going to click on the first one, it should take you to the survey report. There you go. So there's the health, takes you to the health inspection summary, and you should be able to get the survey here. Again, this is all pretty new. So new in terms of the changing to, as I mentioned before, to the care compare. So it's a little bit different from what we've seen before. But here you can get the information, and you could view the full report. I'm clicking on the hyperlink over there. So that's, I think, a really useful tool. And if you're concerned about certain issues, if you want to raise certain issues, I remember when I first started, I thought, these statements of deficiencies, they look so so hard to, like, they're so hard to read and to get through. But what I found is once you get used to them, they kind of tell a story, and that story can be really oftentimes really meaningful. Once you kind of get past the language of understanding, well, this is what is going on here. And what we found over and over again, as I said, we've done a lot of research on this over the years, is that even some pretty horrific care and serious neglect, even when it's resident harm, when it seems very clear that it's resident harm, it's not identified as resident harm. And these are, we use these materials to support our advocacy. And I think it's really useful both in terms of understanding what's going on, but also in supporting advocacy, hopefully in your work. So I'm going to talk next about the two of the data resources that CMS has. It's data.cms.gov, and again, we have these links all over, and I've shared the PowerPoint with Carol, so you can all have a copy of it. So it's data.cms.gov and data.medicare.gov. And when I was working on this and kind of fine tuning this program over the weekend, I went back just to take a look. And I didn't realize this until this weekend, but it appears that they are consolidating data.cms.gov and data.medicare.gov. So as I mentioned before, we'll all, between the consumer voice, of course, and those of you who are using our data, we'll try to keep people informed about about what changes are taking place and how to access this information. but there may be some issues. And I know, I know I experienced this too when I'm first using something, especially that I wonder, am I messing it up? Am I not getting it right? Or is it the data table? So it might be a combination of both. And what I suggest doing is you can certainly, as I'll talk about next, after this part, go back to our website and our data tables, because we will have those links there, as I mentioned before. But it is kind of a difficult time because they have made some changes to this. Difficult time, but also a good time for us to be talking about it, because as I mentioned at the start, we did a program similar to this 2 years ago, and now everything has really changed in terms of where to find data and how to use them. So I'm going to first show you the payroll-based journal staffing data from the federal website, but I wanted to provide some background first. So as of 2010, the federal law has required, this is the Affordable Care Act, so-called Obamacare, required that nursing homes report their staffing for a range of categories: CNAs, LPNs, RNs, administrative care staff, temporary, or contract staff, et cetera, for every single day of the year. Prior to that, nursing homes were only reporting the data on their staffing for a 2-week period before their annual inspection. And just like, as I mentioned about the quality measures before, the staffing data also were never audited by either the state or the federal government. So nursing homes had staffing levels that were, I think they found on average 15 to 20% overstated when they started finally doing this using the payroll-based journal. So PBJ means payroll-based journal, means the data have to be based upon the actual payroll records, and they have to be auditable. So it's a vast improvement. And as I mentioned, when we're talking about Care Compare, this is, the staffing data is so important because staffing is so important to quality care, but also they're so important and valuable because they're by far the most accurate data that we have, period, and the most accurate data that are showing up on Care Compare. So that's really important. Now, unfortunately, even though CMS was directed as a result of the 2010 Affordable Care Act to make nursing homes report their staffing numbers using PBJ data for every day, CMS essentially sat on its hands for years. And it was, I believe, the Impact Act in 2015, which we and the Consumer Voice and Center for Medicare Advocacy and California Advocates for Nursing Home Reform had advocated for, to get CMS the money to direct them to put this system together. So that's why there was such a long time. And the requirement was actually not implemented until 2016. So we only have PBJ data for now the last 3 years, from 2017 on. And those data are published. Nursing homes have to report them on a quarterly basis for every day of the quarter to CMS. I think they have about 45 days after the end of the quarter to submit their PBJ data. And then I would say about a month or so later, CMS publishes those data in the underlying database, which I'm going to show you next. There we go. So here it is. This is data.cms.gov. As you can see here, they also are posting their COVID-19 nursing home data there. So you can find that there as well. We have been collecting and publishing that, updating it, I think about every week or so on our website as well in more consolidated files, because as you'll see, these files are they're pretty difficult, frankly, to look through. But here is the search data sets, which you can see. So that gives you a place to search for the data, as well as I put just this last arrow here just to show you that they also have some data sets that they refer to, in these infographics. So you can see the COVID-19 nursing home data, the Part D prescriber lookup data. There's other data if you went down this page that's available, but I generally just search for PBJ, and that's what I'm going to do now. And this is what comes up. So hopefully this will work. But let me go back to Safari. And so here we are. So this is the page we were just looking at. And I'll scroll down so you can see there's a whole bunch of different things that they're showing here. Dialysis facility reports, blah, blah, blah. Some of this may or may not be interesting to you. It's generally not that interesting to me, but I use this principally for the PBJ. Oh, I think someone is off mute and talking. So if you could please mute yourself. Thanks. So as I just showed you, so this, I just typed in PBJ and I clicked enter, and this takes us to the PBJ, the PBJ files, excuse me. So you can see they go down. This is 2020 Q1, 2020 Q2, 2020 Q3. There are 2 files for each quarter. One of them is the non-nurse staffing for the quarter, and the other one is the daily nurse staffing for the quarter. And these data files provide data for every single day of the quarter for all 15,000 plus nursing homes in the country. It's a huge, huge file. As I said, and I'll talk about it more, we basically drill this down into what we think are important data for every quarter, excuse me, which I'll talk about. The reason why I'm talking about this here, and I want you to see the underlying data first, is because it's also useful. So what we do, not to jump too far ahead, is that we average it out for the quarter for the census, the number of residents, for the staffing levels, et cetera, and then we provide hours per resident day for certain categories, as I'll show you in a little bit. Here, this is really useful if you want to get information on a specific facility for every day of the quarter. So this tells you actually on the outside, as you can see, there's 1.36 million rows. It's a huge file. But this tells you all the different categories of information that are available. So it's the director of nursing, administrator, RN, employee, RN, who's a contractor, et cetera, et cetera. So you can use that, but I want to show you just some of the data and how it can be useful to you. So this is, again, just showing some of the rows, but this is all the, essentially all the data, and you can filter it. And what I do, again, as I mentioned, I'm not an expert on, I'm not a statistician. I'm certainly not an expert on Excel. This is how I use it. I just need to move this over so I can see myself what is going on here. So I can add a new filter condition, and I want to do the, we can just do the first provider, just for ease. So I'm putting in, if you have the provider number, you can use the provider number. You could also search here by city. Why don't we do that? I'll do by city. Actually, first I'm going to do by state because I want to drill down. So I'm going to do state, and I'm going to do NJ. That's my home state of New Jersey. Oops, no, that's it. But and then I'm going to add a new filter condition. So here I can see the provider name, the city, the state, county code, and all the data. And then for provider name, I'll just do, and you can see actually, excuse me, you can go to city, so you can actually even drill down here. And I'm sorry, let me just backtrack quickly. So you can go to city, or you can go to county name. So if you're looking at what's going on in a specific county or in a city, or if you are, say you're talking to a legislator that's covered in covers several counties, you could look at the counties in his or her area. You can see what's going on there pretty easily. And I have to say, oftentimes, as I'm sure you all know, our advocacy as ombudsmen and as advocates on behalf of residents can be frustrating, and sometimes it feels like no one is listening. The only reason why they included the city and the county here is because we advocated for it. Because when these data first came out, those weren't included. There was just state data, and someone would have to go through, hundreds, if not thousands of lines to get to the information that they wanted to. And we're not able to search for a specific city or town. And that can be very confusing, especially even if you're looking for a specific facility. As I'm sure you all know, with chains and stuff, some facilities can have the same basic name. So it's really important to drill down to the state and then say to the county number, I'm going to put in my county, which is Essex, and click enter. And then I'm going to go to here, Daughters of Israel, Pleasant Valley Home. It's I'm going to just put in the add a new filter condition, and I'll just put in their provider name just for ease of moving forward, 315-2029. And I'll press enter. Hopefully that'll give me, since I messed it up. All right, maybe I didn't do that right. I'll take that out again. I'll just say provider name, and I'm going to say contains daughters, DAUGHTERS. Okay, so that gives me this, and now I'm going to export it to CSV for Excel. I want to allow it to download, and hopefully this will work. Usually I use a different browser, but I wanted to just do it in Safari, so it would be kind of new as we were going through it. And of course, where can I find where any of these things went? Oh, here we go. So hopefully that'll be it. Oops, all right, open numbers. Welcome to my computer. There we go. Okay. So this is the data. And again, so here it is again, we've drilled down to state, we've drilled down to county or city, we've drilled down, and here you can see all the different information that's available. So this tells you the quarter, tells you the work date. And so this is what I wanted to get to, because this to me is why the underlying data are so useful, is that one of the issues, which I'm sure you all know, is that nursing homes tend to be understaffed on weekends. They tend to be understaffed on holidays. And I think it's frankly one of the most outrageous problems that I can think of, because it's not the facility's first Christmas. And we allow them to operate it as if it was the first time they ever had Christmas, and they didn't think that they might need to staff up because people will be calling out sick or people will be taking the day off. And so residents on Christmas time, I was speaking to family councils last week, and for Christmas, their residents got a grilled cheese sandwich. That was their Christmas dinner, because the facility just didn't bother preparing to do anything to treat them like human beings on a major holiday. So these data, are really valuable. If you're looking at a specific facility, you can actually see, like this is, let me see if I can highlight it this way. So this facility is, again, Daughters of Israel, for 2020 on 7/21, so on July 21st, it can tell you exactly for all the categories what their staffing levels were. I'll just scroll up, so that includes what the MDS census was, how many hours of director of nursing they had, how many hours of LPN they had, how many hours of CNAs they had, medical aides, et cetera. So this to me is really useful in that way. If you're talking to anyone, whether it be the nursing home about their staffing levels on the weekends, now this is not necessarily a weekend, it's just a day I randomly picked, but you can look and see, like I have a feeling, looking just above it, that the 2 days after it might be the weekend, because you have 0 hours here of RN, director of nursing, 0 hours RN, director of nursing, and you see that, so those must be the weekend hours. Not happening. Here you have 1, 2, 3, 4, a lot of days without a director of nursing, from 7/25 to 7/31, actually continuing through 8/4. So maybe the nursing was on vacation and they just didn't bother to get anyone else in. So this is, again, you're digging in. Again, you really have to, in my mind, do this for a specific facility and be interested in thinking about it in that way, because it would be extremely cumbersome to do that in a, with more than one facility, because as you can see, it's a huge amount of data. It's 93 lines of data and that's be true of every quarter, would be approximately 90 days. So that's really useful. I'll talk a little bit more about these data and how we have compiled them further down, in this program. But that's what the underlying database looks like. That's how I think it's useful if you're looking to find what staffing is going on. And the non-nurse staffing, which we'll talk more about later on again, that includes staffing on for recreation staff. It includes staffing for therapy staff, social work staff, and the same thing. If you download those data for a specific facility, you can see on a day-to-day basis whether there are changes, whether there are days where there is, no therapy staff. We worry that residents on the weekends may not be getting access to therapy. The facility is still paid. The facility doesn't get paid less for Saturday and Sunday because residents' needs haven't changed on Saturday or Sunday, but too many facilities are just not providing those services. So the next data set I wanted to, and this is the second of two, again, the federal data sets, is data.medicare.gov. And this includes essentially pretty much everything else. It includes everything that we saw on Care Compare, but on the underlying data. So I actually got an email from someone this morning who wanted to know if there was a way to find out which facilities have resident councils and which facilities have family councils, not just on a specific basis, but like in a list of them. And this is where you could find that kind of data. So you have information here on health deficiencies, on those quality measures that I mentioned. Ownership information is here. The penalty counts, the risk-adjusted staffing is there, star ratings. There's a lot of information. I'll show you that. And each data set, again, is somewhat searchable because you can find it by nursing home name, by state, by city, by county, and by the facility's address, as well as the provider number, if you happen to have that. So this is what that looks like, and we're going to visit the data.medicare.gov now. And here we go. Oh, is this right? Yeah, data.medicare. Okay. So, and this is what I mentioned before, is that it seems to be, it seems like they are consolidating this. And this is the issue that I had over the weekend in trying to find information, is that I type in data.medicare.gov and I get data.cms.gov, but I don't get the same page as the one that we came to here. So that's just pretty bizarre to me. But in any case, here we are. And so you can see, again, you can download investigate provider data on all these different kinds of providers, as I mentioned before. Here's the nursing homes, including rehab. And this is some of the information that's available. So the first one, SNF, skilled nursing facility, value-based purchasing. I don't generally pay that much attention to it. It could be of interest to you in your systemic advocacy if your state is looking into value-based purchasing. But the provider information is really useful. The MDS quality measure information is really useful. Penalties is really useful. And we're going to explore a couple, at least one of these. But health deficiencies, survey summaries, state US averages. So this gives you information about what's going on comparing different states. A list of ownership, just ownership information for each facility. So essentially, for those of you who are familiar with looking at ownership information on Nursing Home Compare or Care Compare, that provides information on anyone who has a 5% or greater ownership interest in a facility. This is all the data that you can download into one single file. So I'm going to go back and we'll just open up one. I want to see at least the provider information. Now again, huge files. This is 15,348 rows, one for each facility. And these tend to be updated on a rolling basis. So all the data that the federal government has on Care Compare now and on these underlying databases, therefore a 3-year period on a rolling basis, you can access before that through archive files. But generally speaking, what we see in terms of the resident census and what we see in terms of the survey inspections, et cetera, is for the last three-year period. So I'm just going to scroll to the side so you can see, again, the provider number, the provider name, the provider's address, city, state, zip code, phone number, the county, the type of ownership. So you can see for-profit versus government-owned versus not-for-profit, the number of certified beds, the average number of residents. So you can get a sense of to what extent the facility is at capacity, something that is occasionally of interest to us as well. the provider type, whether they accept Medicare and or Medicaid, whether it's in a hospital, whether it's part of continuing care community, whether it's a special focus facility or candidate. I assume that most of you are familiar with that. Very quickly, the special focus facility program is a program that the CMS initiated about 12 or so years ago now, which identifies essentially some of the very worst performing facilities in the country. There's about 88 of them. It's very limited, unfortunately, but for special oversight. And we have materials, I'm sure the Consumer Voice does too, on our website about the Special Focus Facility Program. It says whether they've have that abuse icon, and then I'm just going to, whether it has a resident family council, that question I remember I told you before that I got. Automatic sprinklers, now virtually I think all facilities have that. And then it has the ratings. So this is just a way to really pull out all those data. It has the overall rating, health inspection rating, short stay and long stay quality measure rating, staffing rating, and then this is the reported total nurse staffing hours per resident per day. This is, again, risk adjusted. So it's different from the raw data that we'll talk about in the PBJ reports. And this is the case mix total of nursing staff hours, again, risk adjusted, et cetera. So, and then different cycles apply to whether it's the most recent cycle being 1 year, second cycle, third cycle, and 3 different years. So I won't go through it all, but there's a lot of data. And similarly to what we did before, we can manage those data here. Now this, again, recently changed, but you can include what data you want here. So here it's automatically selected all, but I could deselect all, and I could just say that I want to have the provider name, address, city, state, and the ownership type if I wanted to find out about, and say I wanted to see the overall rating. So I'm going to update those columns. And now this gives me these are all the columns now. So the name, the address, city, state, ownership type, and rating. And say I wanted to do a quick assessment of compare the ratings overall between the for-profit and not-for-profit facilities in my state. I could do that easily here by downloading those data and just averaging out the for-profit versus averaging out the not-for-profit. So this is just one example of ways to drill down. Now, if you click on here, oops, I don't know what that did. Sorry about that. Let's see if we can bring that back. I said it's a little bit wonky with the, see if I can try to reset that. Oh, it went back to the front. Sorry about that. But you can see it's a little bit wonky and it's a little bit new. We and Consumer Voice and Canner and Center for Medicare Advocacy and Justice and Aging, we're talking to CMS. And if you see issues, please do let us know, because we sometimes get hurt about these issues, frankly. They do want to do a good job. They do know that, that these are used by and important to consumers and ombudsmen, et cetera. So I'm going to move on from here. Just wanted to give you kind of a taste of that. And you could always fish around and see, like, here I'm going to look at the quality measures. This tells you exactly what's in it. Measures of quality of resident care. Again, they call it quality resident care. I would say just the MDS measures that are based on resident assessments and make up the nursing home minimum data set. Each row contains a specific quality measure for a specific nursing home and includes the 4-quarter score average and scores for each individual quarter. So you can see what that information is. There are the data dictionaries here, which I go back to all the time. As I said, I'm not a statistician. I'm not hanging out at CMS on a full-time basis, analyzing these data. So I find it useful too to have those dictionaries. Okay, what exactly are we talking about? What are the parameters, et cetera? So that's, yes.
Sorry, this is Carol. You can then sort by any of the columns, right?
Correct.
If you wanted to sort out by city, by state or anything?
Yeah. Yes.
Okay. And then there was one other question. Are you aware of any databases that show medical care by a particular medical director?
No. So one thing that we do, and I'll show you that in the in the data that we publish every quarter, because you saw those underlying data, and that was the one that's over 1.3 million lines, is that we do include the average staffing for the medical director and for the administrator. And I think that's really valuable. I haven't really researched it yet in terms of done an assessment, but it was very interesting to me. We just started, we've done it for 3 years now. So I want to see, whether we can see any patterns there. I just haven't had a chance to do that. So they don't give specific names, but you can see the extent to which there is that staffing in the facility. So, and that's actually where we're going to go to next. So this is our website. It's nursinghomes411.org. And we have data sent to here as I'm arrow pointing to here, that has staffing data, enforcement data. We have data on dementia care and antipsychotic drugging and some general information on facilities. We're actually, just like CMS, we're actually, always thinking about how we can improve how we present these data. And of course, welcome any comments to us about that. But we're in the process of really thinking about, what we want to publish going forward, in addition, of course, to the staffing and how we can make that useful. So one thing that we do provide is we update every few years, every year or so, the citations for, the nursing home citations around the country. So again, these are taken from the underlying data, and we break them down into state files as well as one national file in case people are interested. We do it for over for a 3-year period. So we want to capture what data is on the CMS website and provide that to you. Why are 3 years of data useful is because we kind of want to see what the patterns are. We want to see what the history of a facility is, because the history of a facility is really telling of what is going to happen in that facility in the future. Just like all of us. I mean, I know what how Lori, for instance, is going to act on our next call together, because I've known Lori for years, and I know what I can basically expect from Lori. And so, I mean, that's true of all of us. We're not robots, but we know about how people are going to behave based upon, or we have a pretty good sense based upon our past experiences with them, and that's obviously very, very true of nursing homes as well, especially when we've crunched all of these data. So this is some of the data that we provide. I just want to provide a snapshot to it. This is the citation data. Again, what I just showed before, this is just one section of the tab of the, for Ohio, excuse me. So this is, what we had for Ohio. It shows you, as I hope you can see, tells you, of course, the city of the provider's name, the provider's city, the survey date, and then the deficiency. So we only include the health deficiencies here, and then the deficiency tag number. So I know both our website and the Consumer Voices website has information on what those deficiency tags mean. Of course, CMS has that as well. What is the deficiency citation? And then we have what inspection cycle it was. As I mentioned before, there are 3 years, 3 inspection cycles on nursing home compared at any given time, and the scope and severity. So here you see DED. As I mentioned before, almost all of the surveys around the country, they always cite at D, E, or F. It's always, they never, almost never identify resident harm, and therefore there's almost never a penalty for these citations. So this gives you, we do this periodically. As I said, we're just, talking about, we had a staff call this morning about what we're going to be publishing. Now that it's a new year, what kind of data do we want to start publishing to kind of recap, and let people know where we are in the nursing home world. So you can see the citations here. And this is really useful, I think, if you're looking on a state level, if you're looking on a specific facility level, if you're a local ombudsman, looking in your region to see what is going on, if you're talking to legislators, if you're just doing your own assessment, and even potentially to be looking, for, engaging your surveyors or volunteers and staff to be, well, this facility had these deficiencies in the past. Let's go back and look at it. Let's go back and see, how have they, again, getting back to when we're talking about the statement of deficiencies, how have they addressed what they were cited for? Are we seeing repeats? As you can see here, like Abbyshire Place Skilled Nursing and Rehab shows up many, many times at 25 deficiencies over the 3-year period. It's probably pretty typical, as many of you know. But have we seen the same citations come up? That's an issue. The level of, or the extent to which they're not fixing their problems. They're not following their plans of correction in a way that is sufficient to ensure that they are truly addressing the underlying issues. So I know we've talked about a lot of information, a lot of data so far. This is just really the last part, is talking about what's on our website, where we try to consolidate that, try to make that into more useful, specific pieces for ombudsmen, for legislators, of course, for families and residents, and for advocates to kind of drill in. So if you're concerned about citations, we have this here, and of course, you can always go back to the underlying database. I just want to lastly point out, you'll see there's 3 tabs here. One is OH All, that's all the citations. We also do a separate tab of the citations at harm, anything that's G or above, so people can easily find that. And then the notes gives you the link to where you can find these data on the underlying database. When we downloaded it, again, because we want to make sure that everything that we provide is verifiable and accurate. Even though we are an advocacy organization, it's really essential that we are a trustworthy resource, both to you, but of course, when we discuss things with CMS or with the state leaders or federal leaders. So without further ado, I think really one of the most important things I wanted to share with you all today is the staffing data, again, because to me, they are the best data out there. So this is a snapshot of our staffing page. We provide staffing. I don't know if you can see the top buttons, but we have the federal file. So you can see for every single nursing home, it's daily care staff, it's non-care staff is the second button, contract staff is the third button, and then the fourth button is comparing average staffing levels for each state. And then we put this together in this chart. So you can see the state here. Obviously, this list continues below Idaho, the state's abbreviation, the average total care staff hours per resident day, the ranking in total care staff of the state. So you can see Alaska is number 1, Alabama is number 26. The average RN care staff hours per resident day. Again, as I mentioned before, because those RN hours are critical, and then the RN care rank. Now, Alaska is a really small state, so it's not, I wouldn't take a lot away from that. There's, I think, only maybe 8 nursing homes, if I remember correctly, but you can see where California is, where Colorado is, Connecticut, et cetera. Every single state's included. You can rank them so you can see very easily how your state compares. And then if you want to click on your state, if you want to get the data for your state, you just click on the name and that'll take you to the data. So these are sortable files. Again, it's for every quarter we post it up. I'm going to show you, I'm not going to take you to the website. I wanted to show you what the files actually look like. So this is the file that you would download. I downloaded it for New York. And you can see there are 3 tabs here. So we have the nurse staffing, the contract staffing, the non-nurse staffing. And here's our notes. So you can see this provides on the right-hand side here, staffing hours per resident per day for the state and the national. For every single state, we do this. The notes on what this means, where the data points are, et cetera. And then you can go back, click onto the report, or you can go back to the underlying database. And this is brand new. We started to include a glossary. This is for the quarter. It should be out this week. It's for the 3rd quarter of 2020. So that's the latest data that CMS just published a few weeks ago. And we've been crunching those numbers, verifying them, et cetera, to get them ready. And they should be out this week. So this is Eric, who's our data and communications director. He just gave me a sample file so I could share it with you all today. But you can see these are the definitions for the different, different types of staff. So I want to spend a few minutes talking about what is provided here. So you can see that we just include the state name, we include the provider number at the end. So, I mean, I don't use that a lot, but it's helpful. It's also helpful to make sure that we have verifiable data. But I'll just take you across and show you. So we have, city, county, the MDS census, that's the average resident census. Again, what we do is we take that 1.3 million lines of data and we average it to make it much easier. It doesn't get, again, at the specific day, so we can't find out if a facility has lower staffing on the weekends using the data we publish. But this gives you a really good idea of what the facility is providing on a regular basis for its residents. And that to me is probably the most useful thing, but again, it's not the only thing that's of value because the weekends and holidays and stuff is important as well. So you can, I'm sorry, MDS data, the RN hours, the LPN hours, the CNA hours, total care staff hours. So you can see we just really add these things, the first columns up. The total care staff hours per resident per day. I'm going to make it bigger here so that hopefully you can see. That's another nice thing is that, you're looking at this through my screen, but you can make it bigger or smaller, depending on how you want to look at it. So here's the total care staff, total care staff hours per resident day and total staff hours per resident day. As you can see here, sorry about that. That includes the RN administrator and RN director of nursing. This is something new that we're just starting to include for this coming quarter, is that we decided to include both the RN staff, one figure here on the J that only includes the RN staff that is assigned to provide care. And then the second is really all the RN staff in the facility. Here is RN care staff hours per resident day, and then the total RN staff, including administrator, including the nurse administrative staff and the director of nursing. Just to be very clear again, including the nurse, the administrative nursing staff, as well as the director of nursing. It doesn't mean it's the administrator of the facility. Just want to be very clear here. But in every facility, there is a director of nursing. There may be RN administrative staff as well as RN nursing staff. We include the RN nursing staff, and then separately from also including the RN staff with the administrative staff and director of nursing. I tend to look more as an advocate to the care staff. As I've said to people at CMS, when we talk about these data, nobody cares if the administrator, for instance, or someone working in a back office on insurance claims has an RN degree. That doesn't make any difference. It's not someone who's supervising my mother's care, but they have not been inclined to agree with me. So that's why we include them separately here. We just started doing that. And now you can search by provider. So here, if you open this up, and I hope you can see, it has all the providers, but I could, scrolling back up, I can deselect all, and then I could just go to the provider that I'm interested in, and that'll just take me to the single provider. And so here we have that provider's information if I was looking at a specific facility. And then let me just go back there, and I'm going to select all again, and I could do the same thing for the city or the county. So when I do a training for, say, a local program, I will tell them to select the counties that you are that you're overseeing. Or if you are talking to a federal or state legislator, you can do the same thing. So you can select specific counties, and the same thing for cities. So that to me is, makes it again really useful. If I'm talking, for instance, to a funder in Monroe County, or to an Amazon program in Monroe County, I can just do that to Monroe, and hopefully I didn't lose it. Oh, I made it very small. Hold on a second. Wow, how do I do that? There we go. Screwed up there. Let me just go back. This gives you, oh, there we go. So this gives you the idea. So this is, all Monroe County, as you can see, going down, and then you can select it and see what is going on. You can average it by going down to the, say, total care staff hours, and I go down to the end, and I could do a, there's tools up here for me to do an average, and there I can tell you the total care staff hours for facilities in Monroe County is 444.8 hours per day for this quarter of 2020. And so I think that this, to me, this provides, the most useful information, that these charts, some of the most useful information or data that we put together. This is contract staff, and the reason why this is included, and all of the advocates, urge this to be included in the 2020 Affordable Care Act, is because some facilities have a high reliance on contract staff. It runs counter to, I think, good working conditions for the staff. It also runs counter to consistent assignment and good care for the residents. So you can see, some of these facilities, for instance, this facility has 0 RN contract staff, but the next facility, the Amsterdam Nursing Corporation, has 59.3% of its RN staff is contracted. So that again would raise questions to me, what's going on in those facilities, et cetera. And then lastly, which is what we got the question on, and this is something that we again are looking into more, this is the non-nursing staff. So I'm going to make it a little bit bigger so hopefully you can see more easily. Again, same beginning, the state, the provider name, the city, all this again is just like before, searchable or selectable, so that you can select out the cities you're interested in. You could select out the counties that you're interested in if you want to. And then you have the, again, the MDS data just repeated from before, but this tells you the hours of the administrator, the medical director hours. I mean, look at this. This facility in Nassau County has the equivalent of 0, on average, 0 medical director hours. So my question would be, who's overseeing the care? Medical director has an important role in overseeing the facility. I only have a few minutes left, so I'm going to move forward. Pharmacist hours, again, there is an important role for the pharmacist. We have a lot of fact sheets on our website which talk about some of these requirements. And again, these materials can be used between the data and the fact sheets to support advocacy, et cetera. So we have physician assistant hours, dietitian hours, nurse practitioner hours. We have total social work hours, and we do, just for the social work here and for the activities, we do the hours per resident day. So you can actually see, and look, this facility has 0 hours of activity staff per resident day. Doesn't mean there's no activity staff there whatsoever. It could, but it doesn't necessarily mean that. It means that if you have a census of 376 residents and you only have a part-time recreational staff that's there Monday through Friday for a total of 20 hours a week, that's going to show up as a 0 HBRD. And that's obviously a problem. Here we have, again, the notes and state averages I mentioned before, and the glossary. So I'm going to move on from there. So those are all the data points that I wanted to talk about. And then I'm going to spend the last couple of minutes just talking about some of the other resources that may be useful. And then I could spend some time, as much time as okay with Carol and Amity, to answer questions. So this is, as you can see, we have the data center up here. We have the learning center. We're doing Zoom meetings now for family councils that we're hosting for them so they can have their own private Zoom meeting, especially now that people can't go into facilities. As I mentioned, we have fact sheets, we have some handouts, we have forms and tools for resident-centered advocacy, we have a dementia care advocacy toolkit, and we have a family and Amazon resource center. This is an example of a fact sheet on informed consent. So just to, I don't know if I can make this any, I guess I can. But for all of our fact sheets, and we have them on a range of the nursing home requirements, excuse me, we include a citation to the federal rules, and then a synopsis of what that rule is. And people use these fact sheets to advocate. They use them, I should say, to educate their families and their residents. Family and resident councils have used these, and people can use them to advocate both, within a facility and outside of a facility. When they're making a complaint, too often we hear when people call their state agency to make a complaint, I'm hearing of people who are told, oh, that's not something we handle. You have to send that to the Ombudsman program, which is almost never appropriate. I can't imagine a resident care issue that's not also an issue for the state agency. Yes, it could be useful for them to speak to the Ombudsman, of course, and to go to the Ombudsman for help, but that does not mean that the state should not be taking it in as a complaint that should be investigated. So this helps, can help people to say, well, actually, this is something that falls under the nursing home requirements, and this is something that you should be, taking as a complaint. And we talk very, shortly about the rights of residents in each one of these. We give resources, or here we link to a resource, our website, the Consumer Voices website, and a guide to informed consent. This is the informed consent piece. Here's just a glimpse of our Family and Ombudsman Resource Center. And here's where people can sign up for the Family Council Zoom meetings. And then this is our forms and tools for resident-centered advocacy, excuse me. So we have record keeping forms, both in Word file and PDF file. So people can use them either on their tablet or on their computer or even on their phone, or they could print them out and use that to fill in. But we have some nice forms for like resident preferences, for resident assessment worksheet, because one of the most popular fact sheets that we had was on resident assessment and care planning. So we put together a form for people to use that they can take with them. And then we have family council and resident council meeting notices, et cetera, again, to really help people. And you're free to use this. You can take out the LTCCC name if you want, I don't care. If they're useful tools, you're definitely free to adopt them. We just want them to be out there. We're doing some really interesting podcasts, including with Ombudsman, as some of you know, because we've interviewed a couple of you for those podcasts. Thank you. And also we're doing monthly webinars. And as I mentioned at the start of this program, people can, the Ombudsman programs are welcome to use those webinars as in-service training. If you want us to give you the names of people who attended, please email sarah@ltccc.org to set that up. And that's it for me. Again, thank you very much, Carol, for inviting me. I really appreciate it. Sorry that I didn't get to see many of you at the Consumer Voice Conference last year, excuse me, but hopefully this coming November, we'll be able to be together again. I've really missed it and was sorry not to see so many of you who I've seen in the past. And I think that is it. Yeah, so thanks very much. I'm going to stop sharing my screen. Thanks, Carol.
Yes, thank you, Richard. Appreciate very much. If everybody will hang on, hang on just a second. Louise, I'm gonna call on you